Welcome back, everyone. We're going to continue with the toxicology series and look at cardiac and other common medication toxidromes. So cardiac medications alter the function or rhythm of the heart, and they can be classified in different ways, and there's going to be a different sort of presentation and treatment management for each of these different classes. And so we'll look at classes like antidysrhythmics, beta blockers, calcium channel blockers, cardiac glycosides, ACE converting, enzyme inhibitors, and look at each of those and how they present respectively and what we may need to do to treat those patients. For assessment and management for cardiac medications, we need to use the patient's history and a list of medications to help identify substances that were involved in the overdose. Minimize negative effects. The goal is to minimize negative effects while we determine the antidote. Typically, we can contact med control or poison control early to get them on board and aid and assist with typical presentation and pharmacologic interventions that may be needed. With overdose patients in general, these should be ALS level of care. So if you're an EMT basic and you're arriving on scene for these, you should be requesting ALS backup, and paramedic providers are usually warned specifically for cardiac medication toxicity, as overdose can be lethal and complicated to manage. Let's start with sodium channel blocker toxicity. For sodium channel blocker overdose, we're looking at ECG changes such as the QRS prolongation as well as QT prolongation. Hypotension is going to be secondary to depressed myocardial contractility, and we would expect to see ventricular dysrhythmias for these patients. Beta adrenergic blocker toxicity, these patients are going to present with things like hypotension and bradycardia. Related symptoms such as lethargy and weakness are not uncommon, and hypoglycemia is also common in pediatric patients. For treatment for beta blocker toxicity, one of the things that we'll be looking for is the potential to administer glucagon, as well as rate-supporting and antidysrhythmic medications. And so we may consider things like atropine for bradycardia and hypotension and vasopressors, along with the glucagon for hypotension in these patients. Potassium channel blocker toxicity, these patients can present with hypotension and bradycardia, as well as certain ventricular dysrhythmias. In looking at treating for potassium channel blocker toxicity, we are going to assess for things like a prolonged QT interval, and then we may need to provide supportive care or administer IV magnesium sulfate to treat torsades specifically. Calcium channel blocker toxicity causes decreased pulse rate and decreased AV nodal conduction, as well as decreased myocardial contractility. For calcium channel blocker overdose, medications like amlodipine or Jesus Christ.